Thank you. It's a pleasure being here, being invited by the Brain Tumor Charity. Really appreciate being here. I am from Washington, D.C., and I do not know Donald Trump personally and take no credit for anything he said, although he is into winning. I think all of us are into winning right now, this battle for your children, and that's what this is all about. So what I wanted to do is just talk a little bit about what clinical trials are, and then give you 3 examples of how I think the molecular understanding of childhood brain tumors is going to make a difference now and absolutely in the future going on. Phase 1 trials are the trials where we're really looking for what the dose is for the medication. And for many of the biologics, where phase 1 testing used to be the most toxic dose, it's what's the optimal dose that we get into patients, because many of these don't have toxicities that really get to a toxic dose. Although toxicity evaluation is the primary goal, and you do these in sets of 3s and 6 in families, and we all get very frustrated because we have to start and stop until we get to a specific level before we can go on to the next group. These drugs, especially molecularly, may have signal of efficacy in the phase 1, and there is fairly clear data that for molecularly targeted drugs, if the target is there, even the phase 1s may benefit the patient, and that's very important. So we really need to know that the target is there, but if the target is there, there's no guarantee that a higher dose is going to be more effective. So that's one concept that's really important to realize. Phase 2 is what most children get treated on, these kind of trials, where we're trying to figure out if a drug or a molecular agent is really effective. It's evaluated in specific disease cohorts, although that may be changing. It may be in time evaluated really into specific pathways that are activated among a variety of different children with brain tumors of different brain tumor types. There are often multiple other things built into these studies, and one of the things we sometimes do, especially when there is no real absolute correct way to go forward, and you can't do the next stages of phase 3 trial, is do a series of phase 2 trials and sort of almost pick the winner type of approach. One of the other things we try to build into these phase 2 trials increasingly is something called a phase 0 trial, which is really more of a trial where you give the drug, at the right dose, to the patient potentially before surgery. And after a period of time, it could be a week or 2, measure if the drug actually gets to the tumor, and also, more importantly, does it turn off or hit the target that it's supposed to. And these are getting increasingly important as we look at these trials. And one of the big questions always when you get through one of these phase 2 trials is how do you incorporate what you found into therapy for newly diagnosed patients quickly? Does it mean it's the right therapy for the newly diagnosed? Because many of these phase 2 trials are done in children with recurrent disease, and they may have a slightly different molecular makeup, as probably Dr. Taylor will tell you, than maybe some of the newly diagnosed disease. So you've got to be careful in trying to move these forward or translating them. Phase 3 is the gold standard. Here you have an effective treatment, and you try to prove that your newer treatment is better. The problem is for many of the childhood brain tumors, we do not have effective treatments. So we can't really compare it against anything. So for some of the tumor types like diffuse intrinsic Pontine gliomas, high-grade gliomas, it's really hard to even rationalize ethically going to a phase 3 trial. The outcome measure that you choose is critical in these trials. They have to, if you're going to go through the effort, you've got to get enough patients on the trial, and that's why these trials may take 5 to 10 years, which is really sort of suicidal in a molecular era where things are changing rapidly. The biggest problem, though, to throw these trials away is you look at where progress has been made in childhood brain tumors, much of it has been based on phase 3 trials. So the molecular era really makes these things a little bit more difficult and different. We have to be sure that we study the drugs in the right population, because unlike chemotherapy or radiation, we're not just shooting at the tumor as a whole, we're looking at very specific molecular targets, and if the targets aren't there, we're putting your children at risk for no reason. We have to get these drugs for very specific populations, so there can be some problems in getting the drugs because the populations get smaller and smaller. And one of the things we do very badly in these trials, and Diane talked a little bit about this, is we need to have functional outcomes in these trials. It isn't just enough to talk about survival, but what is the quality of life in survivors? If we're treating a tumor that's behind the eyes, what does the vision look like? And the other thing we learned very quickly with these molecular therapies is we're not as smart as we think. We really think that this is the right target, and then we find out it isn't the right target. And there's a lot of starts and stops here, and we were talking a little bit outside. I think these molecular trials have given us one big step forward, and then we take 3 little steps back. We're still better than when we started them, but we're not where we need to be. And I'm going to try to break this down into 3 examples: medulloblastoma, low-grade gliomas, and childhood diffuse intrinsic pontine gliomas. Now, medulloblastoma, you've probably heard from Dr. Gilbert, most common malignant tumor arises in the back of the brain. It's the example we always pull out for pediatric brain tumors of improving survival, but it's also probably the one we have to pull out as the one where the survivors are getting side effects that are not acceptable, and we have to do better. And one of the other issues is when we have survivors, we have to think about short-term outcome, but also long-term outcome, because when we're talking about survivors, we hope we're getting a cohort of children who are truly cured of their disease. And it may be as high as 3/4 of the patients, but what is the price they are going to pay and the family is going to pay 5, 10, 20 years later? This is the survival curves of multiple studies, and you see on one side is the likelihood of survival. On the bottom is how many years you're out from the study. And you can see, starting from that blue line, moving its way up, these are different randomized trials that were done over decades. And you can see in the past 30 or so years, we've raised survival rates from about 50% at 5 years, many of the children cured, to about 80-85% in specific subgroups of patients. That's great. And that's some of our current numbers. And if you get really good at picking the patients, maybe 90% of patients will be alive 5 years later free of disease. This is extremely good. The problem is, if you take a look at this is IQ. These are where patients on the right-hand side started their IQs, and you see how many points they drop. With standard radiations and more problems with higher doses of radiations, we will drop IQs anywhere between 10 and 30 points by the time the child is so-called cured of their disease. That's disastrous for anybody, but if they start with an IQ below 100 to begin with because of the tumor, its location, any complications from surgery, they're going to wind up in a very limited fashion in the future to be competitive to have families. And that's one of the reasons we have to alter therapy. We have to alter therapy to get improved survival, quality of life, but there are some high-risk patients that we really just don't do well, that are still sitting in the 50-60% chance of survival. And molecular therapy is really our step forward. It's our new holy grail, but it has issues associated with it. For the group as a whole, well, we thought, well, we're smart, we know what we're doing, we've come up with the right chemotherapies with the right radiation, we've just been over-treating these kids with radiation, so we could just sort of reduce the dose of radiation and get as many survivors. And we also have to realize that the price we paid to make the first reduction in radiation has been to add a lot of different chemotherapies that have their own side effects, potentially secondary tumors, hearing loss for a lot of the kids who've been exposed to cisplatin. So one of the things that we decided as a group about 7-10 years ago is that for the group as a whole, because they're doing so well, we can take a second reduction. We've already taken one major reduction in radiation therapy. We're going to come down lower. And this is one of the reasons that we do these phase 3 trials, because this is the results of a study that has just been analyzed, where we took the dose of radiation down, we thought a fairly safe way, from a dose of 2,400 to the whole brain to 1,800 using the same chemotherapy. And we had absolute confidence that this would work, and we just was comparing the groups. And this was a complex look at this, but essentially that's what this study did. This is what the study found, unfortunately. That lower blue curve is the survival rate of the group as a whole, and we haven't subgrouped them out yet. These were kids without disseminated disease, medulloblastoma. The reduction in radiation had an inferior survival rate. That's why you do the phase 3 trials. It's not what we thought, it's not what we all went into it, but we have risked the lives of some children, and for us to make any real advances for these children, we have to understand what we're doing. This is disappointing, and probably one of the things that leaves out that maybe some of these phase 3 trials that take so long make some sense. Many of you have heard about this new type of radiation, proton beam irradiation, that's going to be able to cause less side effects, and there's absolutely less scatter radiation to the thyroid, and you could hear more about it. Maybe Dr. Gilbert talked about it. The problem is that, as we know now, there may be some trade-offs, especially in very young children, because even though the proton beam radiation goes in and doesn't bounce out, so you can be tighter with the radiation, in learning how to use it, we've caused more children to have damage to the inner parts of the brain stem. And once again, the thought that if you're going to do things, you need to do them carefully and not just do them. So one of the problems we have is we really have yet a good handle on how we're going to get intellectually the children better, because we can't reduce the dose of radiation. We also see something like this that Diane spoke about briefly, is that staircase of increasing secondary tumors in children after medulloblastoma treatment. Now, many of these children, obviously all of them were exposed to radiation. Maybe some were predisposed because they had cancer predisposition syndromes that we didn't really understand, and maybe we're going to be smarter in picking those up. But this is a real problem, that we're seeing secondary tumors in this patient population. So what is the Holy Grail? And this is work of Michael Taylor. That's the Taylor et al., 2012. That the biggest step was going to be, all right, we can do what we can with radiation, with chemotherapy, with great surgery. This is where we're stuck. This is where the molecular stuff really starts piling in. And this is his work with a group of people called the MAGIC Consortium, investigators all across the country, that we could break medulloblastoma into subgroups. And it was nice to think about these very distinct subgroups, and we could treat them differently and hopefully improve quality of life. And the subgroups, don't worry about the details, but the subgroups had different survival rates. They had maybe different ways we wanted to approach treatment. This is a great step forward. We realize it's not one treatment, yet our data is all based on this being one entity. We've got to split this apart. And maybe if we try to do this correctly, we can improve survival rates and at the same time improve the quality of life of these children that we're treating. And one of the major keys to as entry into any of these molecular things is you have to be molecularly characterized, have the tumor characterized, a variety of different ways to do it. But in this era, there are molecular genetic platforms that people use, and everybody's got their favorite platform. But they've got to be clinically useful enough that we can make decisions. And one thing you're going to hear in the United States is CLIA certified, or in Europe, a laboratory certified, because if it's a research tool, you can't make decisions based on it. And these tools are there, and they're able to split patients into groups. Now, what are some of the risks that we're walking into as we split the patients in groups? First, a small subgroup, about 10 to 15% of children with medullo, are these Wnt subgroup patients. They have the best survival rates. As we manipulate therapy in these patients, we're starting with a group of patients that have nearly 100% survival rates. And as we decrease tumors, we take the risk that we may not treat them as well. In these and there are protocols moving along with that. For a second subgroup, the sonic hedgehog subgroup, we are looking at a group that seems to do better in infancy, but here we run into a problem that the same subgroup in older children for different molecular reasons are probably our worst group of children with medulloblastoma. So we have to really be careful as we get into this molecular era of what we are choosing for our patients. And that's where the key is with medulloblastoma moving forward, really understanding the subgroups, but also understanding the risks when we put them into the groups. I want to go through two different areas that are also extremely important. The change is already happening. One is the low-grade gliomas. And we really understand this is in a transition because we really were just diagnosing them arbitrarily under the microscope, and there were features that were important as far as outcome, but we didn't know this disease as well as we could. There's a new classification system that we all have to be very educated on. But even with chemotherapy, these low-grade tumors like this one that was left, that white tumor, can disappear. So this is an extremely important tumor to treat, and we know that when using different kinds of chemotherapies, we can get many of the kids under control for 2 to 3, 4 years. But the chemotherapy, unless you have a condition called neurofibromatosis, only tends to work for about 3 years in the majority of patients. And this is the upper curve is kids with neurofibromatosis. So we need to do a little bit better. And about 6 or 7 years ago, we, in a group of children with these low-grade tumors that were just not responding to anything, desperately treated him with an anti-blood vessel agent called Avastin. And this is the first child I treated. That big white thing is the tumor. And it went down to this after 1 month of Avastin treatment. Now, this child had failed radiation, multiple different chemotherapies. The amazing thing with this and the learning on the molecular therapies that are important is we always thought that neurologic problems were fixed. What the problem is what you get. With these children, we saw children who improving their visual acuity and their hemiparesis months after they were just stable, and this is a visual field on top where some of that black area over time disappears. And this gave us our window of opportunity to think that if we can get in with molecular targeted therapy early, maybe we can change the rules to some degree. And then Dr. Pfister and others, Dr. Pfister from Germany and others, showed us that there was a specific molecular change in these low-grade tumors. And more importantly, we had drugs already that could target that molecular abnormality. And that has made things a lot different in how we approach these low-grade tumors, really into molecular targeted therapy. This is a waterfall plot. And this is what happens to the tumor after treatment with one of those molecular therapies called the MEK inhibitors. And all the things on the right-hand side are how much smaller the tumors got over time when they were on the molecular therapy. So this stuff actually works. We just have to understand in which populations, and many of us want to push this in time ahead of chemotherapy if we understand the toxicities better. The other way of treating these tumors, that's one way of hitting that pathway at one point. For a specific group of tumors, we even have a drug that hits directly on where the mutation is with some very nice responses. We have a lot of steps to learn. Are they all going to act the same? Why don't some respond? What is the best of these agents? But we really think that this is an important way to go forward. But we also have to start thinking in this group not only survival, because many of these children will survive for many, many years, but what's going to be the quality of life for these children. And we have to have outcome measures that have visual improvement as one of the outcome measures. So the chemotherapy is useful, and we still just have to learn how to best use it. Now, the last thing I want to do in the last couple of minutes is the diffuse pontine gliomas, because many of you know, and if you've had a child with this kind of challenge, that we don't have good drugs. Radiation works for a while. They're probably part of a continuum from the pons up to the middle of the brain, the thalamus, and can they be therapeutically lumped? And you can do some really nice work, as is Anada Jabota's slide from Montreal, saying that these tumors, depending on where they are in the nervous system, many of them have a specific molecular signature. And maybe our way forward with this tumor moving forward will be to target the specific kind of molecular abnormalities that we see. And this is really something that we want to not lump these tumors, but split them. Now, to do this, we have to know what kind of tissue is available. We need to understand molecularly what is driving the tumor. And there's a lot of complexities, and I think that there are starts and stops in this. These were great ideas, understanding some of the molecular drivers, but they aren't, unfortunately, as simple as we want them. But at least we have a path forward for these tumors, which we've not had. Now, the problem with that is to ask you as families to allow us to biopsy some of these tumors, to get the tissue to move forward, or in some cases, biopsy for this and other tumors at the time of recurrence to make that step forward. And that's a big choice a family has to make, but it may be the only way we make progress and effectively treat your child's tumor. So one of the key discoveries is that something called chromatin remodeling or histone abnormalities underlie a lot of these tumors, and this gave us a window forward. There may be a very specific subtype, about 20% of these tumors, that have a little bit of a different histone abnormality. They may be the Pontine glioma that is more slowly growing, and maybe it's the one that will respond the fastest to a different kind of drug because it has another abnormality associated with it. Maybe these things will just be too ubiquitous to treat. Maybe we're going to have to add things. And one of the things that we really have to get away from for this tumor and for many of our complex tumors is treating with one agent at the time of recurrence. It just doesn't work. We have to, if we're going to get into a molecular world, we're going to have to understand how we're going to mix these molecular drugs with chemotherapy or radiation, or more importantly, with other molecular drugs, so we don't have escape pathways. That means that you as families are going to have to take a lot of risks with us. And it's nice for us to talk about this, but we're not in your shoes. We know that. You're living through that nightmare. We're trying to help. But unfortunately, it's asking your child to be part of we call it an investigation. You might call it an experiment. But I really think that there are directly ways where the molecular era is driving us to make these more rational and not just shotgunning them. So we need tissue to make this happen. We have to balance what we do. Hope. We want to give you hope, but at the same time, not false hope. There are outliers. And in many ways, you're ahead of us than the doctors. You want us to do these things. We have limitations what we can do. The drug isn't approved yet. A drug company is dragging its feet. We're scared because we don't understand it. And I think we're just going to all have to hit a balance together of how are we going to move ahead with these trials. But at bottom line, the changes in trial design are coming. They have to be faster. I don't know if we're going to get away from the phase 3 trials for some things. These agents need not only to be incorporated at time of recurrence, but they have to be put up front in newly diagnosed patients if they're going to really help. And for every type of tumor, and even a molecular subtype of a generic tumor, we're going to have to understand the risks and benefits. And one of the things I haven't told you at all is for many of these molecular drugs, we have not a clue what the long-term risks are, because these are drugs that are often hitting pathways that are crucial in early development and are turned off. And now we are asking you to give them, to block them, or turn them on again. So these are really significant risks, but I think it is the way going future. Thank you.